Good afternoon to all. I'm going to present unusual presentation in child with post-renal transplant. Yeah, this is 9-year-old male child who was born with non-consanguineous parentage, was diagnosed with solitary hypoplastic kidney at the age of 4 years. He was dialysis dependent from 4 to 7 years of age, underwent renal transplant at the age of 7 years of age elsewhere, which was non-biological donor done at February 2019 on immunosuppression with 3 drugs such as mycophenol mofetil, tacrolimus, and prednisolone. These are the pre and post renal transplant serum creatinine values. After Jan 2020, the child lost follow-up in outside hospital due to some COVID pandemic. In outside hospital in May 2021, child had complaints of abdominal pain in the epigastric region, which was severe for the first 30 days, associated with loss of appetite and loss of weight. Child also having fast breathing for the past 3 days. Mother also noticed that the child was unusually pale compared to before. No other complaints. They find out anemia and serum creatinine was 2.1, and for abdominal pain, they done the UJ found to have esophagitis. Biopsy from the above sample showed features of post-transplant lymphoproliferative disorder. Child came here for further management with similar complaints. On general examination, child is alert, conscious, oriented, and mild tachypnea is there, and BP was more than 99th centile. In orthophometry, weight and height was less than 3rd centile. BMI was between 5th to 10th centile. On head and foot examination, child having pallor, surgical scar present over the abdomen. On systemic examination, child having bilateral basal crepitation over the respiratory system. On the abdomen, surgical scar present over the abdomen and epigastric with tenderness. Initial VBG showed some severe metabolic acidosis with hyponatremia, hypokalemia, anemia, and hyperlactatemia. In summary, 2.5 years post-renal transplantation on immunosuppression, suspected acute and chronic renal dysfunction, anemia, chronic abdominal pain, malnutrition, and lower respiratory tract infection. On examination, child having pallor, tachypnea, malnutrition, hypertension, and epigastric tenderness. These are the possible differential diagnoses. Acute and chronic graft dysfunction secondary to post-transplant lymphoproliferative disorders and infections, chronic rejection for complaints to drugs, chronic abdominal pain secondary to esophagitis, gastric ulcer, post-transplant lymphoproliferative disorder, and anemia secondary to infections or PTLD, lower respiratory tract infection, probably viral or fungal. On admission, a child having renal function test with increased urea and creatinine with hyponatremia and hypokalemia. In complete blood count showed anemia and leukopenia. On constellation of symptoms, blood, child having anemia, leukopenia. In kidney, increased creatinine, acidosis, and dyselectrolytemia. We done the chest X-ray, which showed bilateral minimal lower lobe consolidation. On ultrasound abdomen, child having transplant kidney in right lumbar region with increased particle echoes. UJ has showed 2 large gastric ulcers with congested gastric mucosa. PET-CT whole body was done in view of post-transplant lymphoproliferative disorder, which showed mild FDG avidity in the lower end of esophagus and esophagogastric junction. Bilateral lower lobe consolidation also present. No organomegaly and generalized lymphoma was there. On LFT, no features of transaminitis, and child having no signs of any growth in the cultures. Child also having mild low range of calcium. In viral panel, child having CME viremia with viral load of 2,821 copies per ml, and also biopsy from lower esophagus showed some cytomegaloviral inclusions. So we made a diagnosis with acute and chronic graft dysfunction, anemia, leukopenia, pneumonitis, esophagitis. These are secondary to CME syndrome with end organ damage. Moving on to CME. CME is opportunistic infection in 20 to 60% of transplant recipients, but in renal transplant patient, it is only up to 8 to 32%. Pathogenesis, CME primarily residing latently in T lymphocytes, endothelial vascular tissue, polymorphonuclear cells, and also in renal epithelial cells. Following infection, CME infiltrates and produce antigens, upregulation of interleukin 2 and inhibition of interleukin 2 gene production, secondary to cyclosporine. It also down-regulates the MHC1 molecule. Diagnosis, mainly made by non-invasive measures of antigenemic assay and nucleic acid testing. Gold standard was a tissue biopsy of an affected organ. We done for our child of CME PCR, we showed 281 copies per ml, and biopsy showed CME inclusion in the bodies in the lower esophagus. Coming to treatment, combination of immunomodulation and antiviral therapy is the main mode. Reduction of immunosuppression is an important adjunct to the therapy. Ganciclovir 5 mg per kg twice daily for minimum of 2 to 3 weeks or longer if CME viremia is present. Oral ganciclovir can be given. CME hyperimmunoglobulin was approved originally as a prophylactic agent. In our child, we stopped the mycophenolmofetil and tacrolimus dose was reduced. Steroid dose was increased. Started the child with IV ganciclovir for 1 week. Then renal parameters after improving, we started on oral ganciclovir. On admission, the renal parameters is on discharge, the child improved with renal parameters. Take home messages: infections are the most common complication leading to the graft dysfunction at any time period. Constellation of esophagitis with gastric ulcer, pneumonitis, anemia, leukopenia, graft dysfunction was the pointer towards CME syndrome with an end organ damage. Presence of CME viremia and documentation of inclusion body in the esophagus biopsy was helped in diagnosis. Follow-up after renal transplant is very crucial. Thank you.